So the most important question is, we have two agents. They were tested in very similar settings. Which one should we use first? They've never been compared head-to-head. So regorafenib was compared to placebo in a large study that essentially showed superiority to placebo in all parameters. TAS-102 was also compared to placebo and also showed an improvement in all efficacy parameters. So the question goes back to, which one of those agents should we use first? So we don't have any guidance. The only little bit of guidance we have comes from the recourse study, which is the TAS-102 versus placebo, where patients were about 20% of the patients were pre-exposed to regorafenib, and those seem to do as well as those that haven't been pre-exposed. So we know if you give regorafenib first, TAS-102 preserves its activity, so regardless of positioning. Unfortunately, we don't have that data with regorafenib and TAS-102 prior. We also have some hints about where does regorafenib work best. So there's one study called the Concur, which essentially was an Asian study, and that study looked at patients where 40%, about 40 to 50% of those patients did not have exposure to anti-VEGF or anti-EGFR therapies. Now, what this study suggests, historically compared to CORRECT, which was the initial regorafenib study, is that the deltas between regorafenib and placebo were bigger, meaning that regorafenib seems to confer a further benefit if moved up the line. So the later we wait to introduce it, the less likely we're going to get a benefit.